Thanks very much, everybody, for joining the webinar this afternoon. This is one in a series that we've been running over the last, I know, a good while at this stage. And there's a particular, I suppose, significance to us holding this webinar on this date, and I'll come back to that in a minute. But the key purpose of it is to have an exchange of information about what's happening, and so that people can know what's happening in their own area. What we have found in the past is when we've done these webinars that what's worked well is for the opportunity for people to ask questions, and I think we've done okay. We haven't been able to answer every question that was put to us, but between most of us on the panels that have been in attendance, we have actually been able to deal with a lot of the questions and to deal with them quite quickly. So we're gonna we have some slides, and that's necessary. We actually have to talk through the slides so that people can have an understanding and see where we're at as well. But we're going to share those slides out with everybody, so you'll have them and you'll be able to refer to them and you'll be able to look over them. So if we go through them very quickly, don't worry about it. The reason that we're doing that is to try and cover a lot of ground as quickly as we can and leave as much time for questions as possible. So I better show a little bit of leadership on this one now, and work through my allotted time slot as quickly as possible. So I have just three messages that I want to convey to you, and I'll try my best not to do that quickly and to do it efficiently. The first one is the significance of this meeting today is it's the 4th of March. Yesterday was the 3rd. The 3rd of March was we did that. There was a lot of work done over the last well, I suppose you could say it's gone on for over 2 years, but intensively since October, to try and get ourselves ready for the establishment of the new IHA structures, and we achieved that on the 3rd of March. Now, that's not to say, and this will be repeated as we go on through the webinar, it's not to say that it's a job done and we walk away. In fact, actually, it's the exact opposite. It's the start of a process. We have made some significant changes on the 3rd of March, but there's lots more work still to be done in terms of bedding down the existing structures, developing them further, integrating them with the networks of care, and so on. That work will continue for the rest of the month of March, into April and May, and probably there will still be some of it being done right through to the end of this year. So the challenge for us is to make sure that we stay the course. And that's important because while the regional structures have served us well in terms of regionalising our national health service, the IHA management structures are really important because that's the level at which services are delivered. That's where patients receive care. That's where service users receive care. So continuing with it and staying the course with it over the course of the rest of this year is really important so that we get the most out of that. So that's my first message. Second message is that we have made some changes to the regional health area management team, and they're relatively minor because we hadn't a whole lot left to do at this stage, but we had a number of posts that were to be filled. We've made progress with 2 further appointments and recruitment to a 3rd. We have the regional regional director for HSCPs is Elaine Dobell, and Elaine is joining us on the webinar this afternoon, waving at you all there. In post now for since last week, and I suppose a really important addition to the regional health area management team, and we'll be in touch with you over the coming period, no doubt. Second person, again, somebody I suspect is well known to lots of you, is Edel Quinn. Edel is currently working in the Northwest. Sorry, was previously working in the Northwest, but at the beginning of this week, she switched over to the role of Regional Director of Disability Services. And while she'll still be physically located up in her home county of Donegal, she will be part of the regional management team and leading out on our disability services at regional level. We've held interviews for the Regional Director of Nursing and Midwifery, and we would expect to make an appointment to the management team from that competition in the near future. Hopefully we'll see that through, and we'll have somebody in that room as well. So that's my second message. My third one is a reminder that all of these changes that we're implementing are all being implemented in the context of business taking place every single day. You don't need me to remind you that of what's happening in GP surgeries today, what's happening in our mental health services today, what's happening in people's own homes where we've got home care being delivered, or we're public health nurses visiting first-time mothers and so on, what's happening within our hospitals and our emergency departments and so on. You don't need me to remind you because that's what you live every single day. But I think it's important that we remind ourselves that the changes that we're implementing to our management structures, we're doing that in the context that all of that work must continue uninterrupted and unimpeded in any way while we're doing it. And that's not easy to do. It's very difficult to take time out of the day-to-day, especially when it's a very pressurized day-to-day to be able to do it. So I do want to acknowledge the fact that people have done that and have committed to this process for well over 2 years at this point, committed to it intensively since October, and have now produced the results that have allowed us to stand up the IHA management structures since yesterday. I know there's work still to be done, but I do want to at least take the opportunity today that we reflect on the 3rd March for that reason, that people have put in significant effort and time to try and make sure that we have management structures that bring services closer to where people are living and work. So I'm handing over to Mary. I probably exceeded my time limit slightly, but I'm going to hand over to you anyway.
Okay, thank you, Tony. And this slide just reflects exactly what has happened on the 3rd of March. So individual IHA management teams have been stood up, and that includes the general managers and the integrated service leads that are appointed, reporting on administrative function directly into the IHA manager. The clinical representation of those management teams has yet to be confirmed. It will be very important, both from a nursing, health and social care professional and medical representation on those, and we're working through with our colleagues on who they will be. Recruitment and reassignment has progressed for the general managers and the integrated service leads, with 2 or 3 posts to be filled, and we expect a completed target date of the end of March. There will be an interface between the network of care and the IHA management teams, and that is agreed at a starting point to be quarterly. And again, the detail of this is going to be worked out in the coming weeks and months. There are now separate IHA performance and accountability meetings. Up to date, these have been joint across the West, with the West and the Northwest. The integrated service leads and the general manager's core administrative teams are currently being reconfigured and aligned to their offices in line with the reassignment principles. All of the enabling regional teams have arrangements and ways of working to support this IHA structure for phase 3 of the implementation. The mobile vaccination teams have transferred to public health. Our networks of care working group proposals are finalised and implementation plans are being confirmed. And as Tony referenced, our regional lead and regional director of health and social care professionals have been appointed. It's important to note that the entire programme remains under the governance of the programme steering group, and a key partner in that programme steering group is the patient service users. And we will continue to engage with that group in relation to the development and co-design of our services as we move forward. So I'm just going to talk through the various phases of where to get to where we are today and how we move forward. So for November and December, we spent a lot of time designing and mapping our care group lens workshops, getting our gap analysis, identifying our risks in order that we could look at an operating model and our readiness trackers and set up local implementation groups. And these local implementation groups oversaw all of those pieces of work that were required for the implementation and go live date of the 3rd of March. Throughout January and February, the IHA management teams were finalised. The current to future service mapping continued to be worked through, along with reporting relationships and portfolios. The ways of working arrangements have been agreed, and operating models have also been agreed. And each of the local implementation groups conducted a self-assessment readiness framework, which informed Tony in relation to what changes could be made safely on the 3rd of March. So as we've already referenced, a number of moves have been made for the 3rd of March, and that allows us now to move into the next phase of bedding down the IHA operational model and structures. It's important to note that the first 2 to 3 weeks of March, all of the integrated service leads, which were already known as the previously known as the heads of service, will hold on to their operational governance per care group until such time as the due diligence, knowledge handover and transfer is complete. Phase 4 then will be the stabilisation and embedding of the model and our final outcome will be an integrated model of service delivery within a CHA and IHA. So when we were transitioning or getting ready to transition into phase 3, there are a number of principles that we adhered to. The principles of readiness and sequencing, so each of the IHA's readiness findings to inform the timing of the transition, the sequencing of the services, governance and controls required prior to transfer, and the transition plans for each IHA were very specific. It was a key component of the transition was that there would be no service transition without appropriate governance in place. So that meant that the general managers and integrated service lead portfolios were aligned to the approved IHA CHA model. The IHA management teams are stood up. The terms of reference for those management teams are agreed, and the administrative compositions within the integrated the ISLs and the CHA manager's office were clarified, and then the structured service handover framework was defined to ensure a safe transition. And that has started from the 3rd of March, and that will continue out through March, April and May. And the transfers are all sequenced by readiness and complexity, supported by the structured handovers, subject to due diligence confirmation, and the majority of services will take a 2-week handover window in order to fully hand over to the giver and the receiver, both the integrated service lead and the general manager. It's important to note that on the 3rd of March, the regulatory continuity and the delegations for regulatory responsibilities remain as is. So there's no statutory regulatory role changes for either the PPIM, the PIC, the registered provider nominee, or the registered proprietor. All those current arrangements remain in place. And throughout March, April and May, they will change as handovers complete. The regulatory mapping and ways of working, as I said, will be completed by the end of March. And the current post holders remain in role until the formally regulatory process and handover is complete. This is the plan on the page that we use to inform and keep us, the programme steering group, on track. And you'll see the go live date there of the 3rd of March. In terms of communication, this webinar is one of those parts of communication, but equally a number of newsletters have been circulated out into the system. And once the management teams are established within the IHAs, each IHA will have a webinar to communicate with all of the staff within their area. And those communications, newsletters, webinars will continue well into next year as we develop and change as part of the process. To support the integrated service leads and the general managers in taking up their new roles in this integrated model of service delivery, there will be an LLTM programme which was co-designed by the general managers, integrated service leads and others to meet the specific needs of those who are taking over new briefs, and also for everybody who's involved in the delivery of this new model of care. And that will start in April. As I previously referenced, the administrative alignment for integrated service leads and general managers is underway at the moment, and the full management team, including the clinical representation, is expected to be formalised towards the end of April. The ways of working, particularly around the current care group structure into the new IHA-CHA model, are being defined, but also there's room for manoeuvre in relation to those as we develop and change. Our colleagues in mental health and in the mental health network of care have been charged with looking at how CAMS and the adult mental health teams will be aligned to the CHA model, and there's a timeline being worked on in relation to that, and that's part of the ways of working. The local implementation groups will remain in place as the change continues to be implemented. And as I said, the handover and knowledge transfer will continue throughout March and April, but it will also continue once everybody's in place, because there's very few that are leaving the system, and the expectation is that colleagues will support each other with any queries or any learning that's required, even much further out than April or May. So as we've already said or mentioned in previous, the mobile vaccination teams have transferred under public health, and the health and wellbeing element is being finalised at a national level with our union colleagues and will be due to transfer in the next couple of weeks. The enabling functions have all agreed an operating model to support this phase of the IHA implementation programme. There'll be changes in some, but once those models are fully resourced, there will be further changes. But it's very important for everybody to note that the enabling functions such as QRSM have put a process in place that everybody will be aware of the management of how to manage incidents, the escalation processes, and they will go into some detail on this later on. And the networks of care, which we have committed to expanding original ones and developing new ones, are well underway, and they'll be a very important part of our process and of our operational model within an IHA. So I'm going to move on to individual IHA structures, and I'll cover the Mayo structure, and my colleagues then will cover each one of their individual structures. So this is the Mayo IHA. It's made up of 3 community health areas and 1 hospital, that's Mayo University Hospital. The integrated service leads are accountable for the delivery of a specific portfolio of services within the IHA, including higher complexity, specialist service and regulatory oversight. In Mayo, there are 2 integrated service leads, Seamus Byrne and Charlie Meehan. There are 3 community health areas and a general manager will manage each area. At the end of the process, and once the model is fully implemented, these managers are expected to have full operational and budget accountability for the majority of community services within that area, including CDNTs, community healthcare networks, home support, and when other services are aligned, adult mental health services and CAMS. In Mayo, there are 3 general managers, and those general managers are Jerry McCormack, who have responsibility for the Mayo North Community Health Area, Steve Jackson, who will have responsibility for the Mayo South Community Health Area, and just appointed Maura Kelly, who will have responsibility for the Mayo West CHA area. The hospital managers will continue to maintain operational accountability for all services delivered within the hospital, and the hospital manager in Mayo, for Mayo University Hospital, is Catherine Donoghue. And this is just an example of the overall organogram with everyone's names populated. You would be very familiar with these in the pink and the purple boxes. And I suppose it is very, very important to say, though, that over the next 4 to 6 weeks, that the current integrated service leads who previously were heads of service will maintain their current operational governance within care groups until such time as the handover is complete. And that's just kind of a reassurance to everybody that we will ensure safe handover and safe delivery of service in the new model, and particularly in the transition phase. Next slide. I'm going to hand over to my colleague, Anne Cosgrove, IHA Manager for Galway Roscommon.
Okay, thanks, Mary. So for the Galway Roscommon area, there are 6 network areas: North Roscommon and North East Galway, Tumath and Ryloch Ray, West Galway City, East Galway and South Roscommon, and Central Galway and East Galway City. And we're kind of moving to using the geographical names as distinct from network numbers, which would have existed. Mine would have been networks 4 to 9. I think it's easier to associate with the geography than it is with a network number. So in terms of the team, and I'm not going to repeat the points Mary have said, all of which apply in terms of people holding their existing portfolios until such time as complete knowledge transfer has happened, and all of the due diligence processes. But the 4 ISL leads for Galway Roscommon are Mary O'Halloran, who people will be familiar is currently was in the Head of Service for Disability Services, but she's now ISL lead, and she's in the process of knowledge transfer with Emma Ganood. Emma has joined us recently from another region, and she will be ultimately looking after our Section 38s, 39s, in particular disability services. And as I say, some work has started on that already. Melissa Kelly is in post. She's our ISL lead, and she will and has currently and will continue to have a regulatory responsibility in relation to older person services. and Elaine Prendergast, who's currently holding her health and wellbeing portfolio, but she will have a responsibility in relation to a range of primary care services, CAMS, and that will become clearer as the knowledge transfer, etc., takes place. In the 6 community health areas, we have 6 general managers. Connie O'Connell, who is covering the Central Galway and East Galway City area, Colette Ansborough, West Galway, Denise Dunn, West Galway City, Emma Naughton, Tumath and Ryan Lochray, Jean Gaffey, East Galway and South Roscommon. Jean is joining us from another region and she'll be with us in the last week in March. And Jan Flanagan, North Roscommon and North East Galway. And again, most of these have an existing portfolio which they continue to hold while we're completing the transition process, the knowledge transfer, the due diligence. And within my area, we have 3 hospitals, Galway University Hospitals with 2 sites, UHG and Merlin Park University Hospital, led by Chris Kane, General Manager. Portiuncula University Hospital led by James Keane, and Roscommon University Hospital led by Mary Durley. So this is my immediate team, but as Mary has indicated earlier, in terms of the management team, it will have HR, finance, ICT, and the clinical representation in terms of medical nursing, HSEP. So it will be fairly, I suppose, a fairly large management team as such. This is the organogram reflecting my structure. I suppose I'm not going to go into it in detail. I think it's fairly reflective of what Mary has outlined in terms of the portfolios. There are specialist regulatory portfolios for the ISL leads and other regional services that cut across our IHAs, etc., that will continue to be managed. But I suppose, if people have queries afterwards, we can go through them, but I don't propose maybe going through them just now if the slides are going to be circulated to everybody, if that works for everyone.
Thank you, Anne. Dermot?
Good afternoon, colleagues. Donegal has 2 ISLs that are Mandy Doyle and JJ McGowan, who are both, Mandy is currently Head of Service Primary Care and JJ is incoming and has taken on a portfolio from ADL covering disability services, given her move to the regional post. And I do want to also pay tribute to the massive contribution ADL has made to changing the complete direction of disability services in Donegal and leading that with her team. So I wanted to recognise that as well. There are 4 community health areas in Donegal. As you can see, there's Inishowen, Donegal East, Donegal North, Donegal South and West. Each of those have managers attached to them and they'll have operational budgetary accountability, including primary care, CD&Ts, home support, CAMS, adult mental health, etc. So incoming for Donegal East, we have Claire McCrory, who's currently the manager of the Chronic Disease Management Hub in Letterkenny. Jude O'Neill, who has joined us from Dublin North East. Jude has a significant experience in a number of areas across, none less as an inspector under HICWA previously, but also as a head of social care previously in the CHO 8, I think it was. Maura will be the Inishowen CHA manager, and Maura currently is the GM for primary care services across Donegal. We also have Denise Curran then, who is day service manager for disability services and is covering Donegal North. Denise is also retiring at the end of this month, and there's a recruitment process in place to fill that post. But I also want to acknowledge the long career that Denise has had and has been in disability services, majoritively with a small exception of a secondment to health and wellbeing in Dublin a few years ago. Wish her well in her retirement. Mary McGorty is currently Disability Services Manager of Donegal and will continue to provide the GM role for that service. Main reason that Disability Services have a dedicated manager in our area and in John's area in Sligo Leitrim is because of the model that we have here, which is 75 to 80% HSE delivered services, which is quite unique from other parts of the country. The hospital managers continue, and our hospital manager in Letterkenny is Sean Murphy, and the model there, as you can see, is no different to other models that are put up. So you've Sean, Mandy, Maura, Claire, Denise, Jude, Mary McGroarty. So that gives you an outline of it, and then you have JJ. So I now pass you on to John.
To John.
Good afternoon, colleagues. Yeah, so similar, I won't repeat what's already said, but similar in terms of obviously the design and structure, in terms of that we have 2 integrated service leads in Sligo, Leitrim, West Cavan and South Donegal. That's going to be Cara O'Neill and Frank Morrison. Cara and Frank are existing, or would have been existing, heads of service, and will be moving to the new portfolios over the coming weeks and months. There are 2 CHAs in Sligo, Leitrim, South Donegal and West Cavan. You have Sligo, South Donegal, and then you have Leitrim, West Cavan. You'll have, similar to my other colleagues, you'll have a general manager that will manage each area and the responsibilities and accountabilities that come within that. So for Sligo, South Donegal, that's Emma Ball, and for Leitrim, West Cavan, that's Lynn Stothart. We also have a general manager for disability services, owing to what Dermot said there in terms of the rationale for that is the level of direct provision directed to the HSE, and Nuala Gallagher will be moving to the General Manager Disability Services portfolio over the coming weeks, and that's been planned out and transitioned with Edel. As Edel moves to a new role, she still will support the transition over the coming weeks, and Nuala and Cara will be moving into the ISL with specific responsibilities for disability, and Frank Morrison will have specific responsibilities for older person services and mental health. The hospital manager, obviously, is similar to other people, will continue in the current guise, and very lucky to have Grania McCann in that role. And obviously, apart from Sligo University Hospital, we also have Our Lady's Hospital in Manorhamilton. So again, without getting into too much detail in it, in terms of similar to colleagues, obviously the management team is being stood up. We'll be adding to that with clinical representation. We have the business supports that are set out there. And over the coming weeks, we will transition fully to the operating model as set out. That's it for me, because I don't want to labour what's already been said. So thanks, Mary.
Thank you, John. So I'm just going to give a quick overview in relation to the networks of care, and Pat Nash, the Regional Clinical Director, has to send his apologies for this webinar. So I'm just going to present on behalf of Pat. So as we've previously stated, the networks of care are an important development in a parallel with the implementation of the new IHA structures. And the Regional Network of Care Blueprint, the final version, is in progress and is being agreed. And as we said, the interface between the networks of care and the IHA management team is agreed to be at a minimum a quarterly basis, and the detail around this is going to be worked through in the coming weeks. And as I said, the clinical representation on the IHA management teams is also under consideration. The existing hospital IMCAMs are moving to the integrated networks of care, and the proposals and recommendations for this are under consideration. Some will require more extension into the community than others, so we're working through that. The Mental Health Network of Care working group is established with co-lead of John Fitzmaurice and Dr. Mandy Burke, who has been appointed as the Mental Health Network of Care Director. And that final proposal is being submitted to both myself and Pat for approval. As I said, the Mental Health Network of Care have been charged with looking at how we realign the current adult mental health services and CAMS within a CHA. And I suppose at this point, I'd like to also note Charlie Meehan, who is also retiring, but Charlie has been dedicated and committed head of service for mental health for a long number of years, and was very involved in the development of the network of care. So similar to others, we'd just like to wish Charlie well in his retirement. The Children's Network of Care is being co-chaired by Dermot Monaghan and Dr. Hilary Stokes. And again, there's most of the structure is complete, with the final proposal submitted to both myself and Pat for final approval. Similar, the Older People's Network of Care is just at its final stages of completion before it's submitted to myself and Pat for final approval. The Disability Network of Care, again, there was a final workshop on the 23rd of February, and that's submitted now for final approval. The Primary Care Network of Care, again, is at the final stages of completion, and the subgroup workshop was held on the 26th of February. And there's just a final review by the subgroup members this week before progresses on. So that's the network of care, and we're going to hand over now to each of the regional labelling functions, who will give one slide presentation in relation to how they will support the IHA over the next number of weeks while we're in phase 3 of the transition. So first is John McElhenney, Quality Risk Safety Manager. John, do you want to take it?
Yeah, thanks, Mary, and good afternoon to all. I've worked on this on behalf of the acute services with Dr. Ramona McLaughlin, and also we've had the support of Shannon Glynn and Philip Judge from the community. So it's an integrated approach to designing the enabling function for quality, risk and safety management. Previously in the acutes, it would be in QPS, quality and patient safety, and in the community, quality, safety and service improvement. So our new acronym there is QRS management. So really, in us looking at these different core functions, we had to be adherent to statutory and regulatory requirements, to the national policies and procedures that govern this area. So we've been, really, it's been a due diligence effort in making sure that we're in conformance to those. We've also carried out an extensive stakeholder engagement, and I see a lot of you who participated in that are on the call, and thank you very much for that. It has informed a lot of what you'll see on the slide here. So there are certain core processes and structures that we have to develop and integrate now as we move forward since yesterday. And we've done a lot of work already on doing that. Probably the more high profile areas would be things like incident management, risk management, and then all our regulatory requirements as well. So currently the incident management processes will probably change more in the stylistically, with local incident management will still be carried out at CHA and hospital level. And those structures and processes will not change. It's the same thing where the incident occurs, the initial preliminary gathering of facts, the consideration of those facts, and then the escalation up to the network level to determine whether further review is necessary. All those structures are currently in existence in both the community and the acute services. It's just that possibly the names will change. So our networks of care will play a key role as a network incident management team, and those will be stood up over the coming months across all of our networks as they become operational. The risk management side of things, really, we will be developing risk registers. Currently, everyone will have a risk register in place, but I think at regional level, we will be developing a risk register for that. At national level, there is a already stood up a regional or a national risk management or quality and risk function. So we are having to feed into that already. So we will be trying to stand up our risk management processes fairly soon. The areas of open disclosure, assisted decision making, protected disclosures, all those types of areas, radiation safety, health and safety, the structures and processes and that will not change, but they will evolve as the whole new structures become embedded. And we will have a degree of flexibility in that to ensure that we can change our processes to match what the operational model will be. So I'll hand this be finished. Thanks for your attention, and I'll hand over to whoever is next. Caroline.
Thanks a million, John. So we'll go through this quickly. These slides will be shared, as it's been said before, and if you have any questions, you can always come back to us. So the press function has already fully integrated across the old community healthcare areas and the acutes, and that's been implemented for the last year and working well. That's across press and comms. The change, I suppose, are from the 3rd of March will be across the PQs and reps, where we have now updated the parliamentary database to ensure that we HSE will be copied on all PQs and reps that are issued out to our whole region, just to give us further oversight and governance overseeing. We will be there to support with any difficult or controversial or topical PQs and reps, and we will be providing details of previous responses, whether to the CEO or the DOH or even just internally or through media. So we hope that that will be a significant support for the new services on the ground and people taking over. We have central intake email addresses where staff can contact us with anything that they need to. For internal comms, it's there, Comms West Northwest. All media queries will continue to come through Press West Northwest as they have been for the past year, and we will be issuing those out to the services as we have been doing. Public affairs is a new one, I think, for a lot of you, but we'll be copying in on all political correspondence, and as a result, you may well be getting engagement from us through that email, just engaging on queries or public reps that we need to close out on. The one area that will fall under the comms and public affairs function that isn't moving quite yet is FOI. And I appreciate that a lot of you who are involved in FOI will know it is very detailed process. So we won't be making any changes to that process or the people carrying out that role at present. We will be setting up a working group, and we are engaging with the national teams and the national FOI office on what that will look like. So that's still a work in progress, but I suppose just in terms of anyone who carries out that role at present, that does continue, and there's no change to any of those functions at the moment. All that we will have is that for non-personal FOIs, that our public affairs email is copied so that we're aware of them coming through the system, and also in cases where we may be able to provide some supportive context. And really, well, that's it. I'll move on.
Thanks, Caroline. So I'm going to hand over to Liam for finance.
Where we are at the moment, okay, the finance function and reporting relationships will remain the same as pending the approval of the finance structure. Currently, our finance structure is a subject of negotiations nationally with the union, so hopefully that will be resolved in the next few weeks. From today, or from the 3rd of March, right, 2 finance members will basically attend each of the management team meetings. So one from community and one from acute services. So that arrangement is in place as from yesterday, and it will continue in place until basically the finance structures are agreed and basically the IHA finance leads are appointed. Okay, the current regional finance function will remain as is pending the approval of the finance structure, and the current IFMS purchasing groups will remain as is pending clarifications on the ways of working in the CHAs and the ISL. And when budget ownership transfers, we will amend the purchasing groups to reflect the change in governance. Okay, so these we have a team in place to basically assist with this process and provide support and basically help to basically to establish the new purchasing groups as they arise. Okay, so at the moment we are reporting by care group, and we will continue doing that for a while. But going forward, I think there will be basically a requisition that we will have to do a certain amount of care group reporting as well as basically IHA reporting. So there is mapping and attributes on IFMS that will allow us to do that. And then the current cost centres remain in place, but the mapping for the IHA structure is there in the background, ready to be progressed once we go past these dates. Thanks very much.
Thank you, Liam. And next we have Maria Ferguson.
Hello, colleagues. So in relation to HR, the HR model has been progressing over the last number of months. Unlike some of my colleagues, we have concluded our engagements with Borsa in relation to the structure and the design of the regional operating model for HR. So agreement was reached in December of 2025 on what the new HR model for the regions will look like. Over the last number of weeks, appointments have been made to the new integrated roles. So my colleagues Siobhan Moore, Enda Maloney and Aisling MacDonald have all been appointed to the new integrated roles for the human resources function for the West and Northwest region. Within the model, the focus will be on supporting the IHA management teams, the networks of care and the regional management teams. So over the coming days and weeks, we will be writing out to all of the services, identifying who your lead points of contact are in each of the IHAs, but also in relation to our regional services. So one of the new benefits that's coming with the model is that there are going to be 6 regional services in the West Northwest supporting HR. One will be in relation to regional employee relations, so there will be a dedicated regional support for line managers and staff and IHA management teams supporting employee relations. There will also be a new regional recruitment service, and we're working at the moment on a standard operating procedure for that regional recruitment service, who will have responsibility for supporting entry grade recruitment in clerical admin grades in nursing and in HSEP also. There will also be a new regional learning, training and development department, and we've been working on that, and we will be putting in place a multi-annual training plan with services for the region also. There is a new regional workforce data pillar supporting services with information and data around our workforce. Also, a regional medical workforce pillar is going to be established in the region in the coming period as well. And we're working with all of our sites around medical workforce and what that design will look like and what functions it will have. And then finally, the Occupational Health Service will have a dedicated pillar in the new HR model in the West Northwest, with a focus on supporting staff to return to work, also supporting our work around absenteeism and staff health and wellbeing. So quite a lot of work has gone on. There are some areas here that we're continuing to work on. Over the last number of weeks, we've been engaging directly with our own teams, and I want to take the opportunity to thank all of our HR colleagues across the region who engaged for many, many months on the new design for the region and fed into the final operating model, which we have agreed as well. There will be a director of HR on each of the IHA management teams as well, and they will be supporting your IHAs as we move forward. So in the coming days, as I say, we will send out a communication to all services on who your points of contact are under the new arrangements. And that's it. Thank you, Mary.
Thank you, Maria. And Vincent.
So thanks very much, Mary. And you'll all be glad to know this is the last of the communications around the capabilities and the enabling functions. So within the digital function, staff reporting lines remain the same. The work that the digital staff have been doing for quite some time now to try and support integrated working, that will continue, and we will strengthen the links between the different elements of the digital teams to continue to support how we provide integrated care around the patients. So we'll keep with that. We will review this in the third quarter to make sure we continue to stay aligned with the IHA and the services operating model. The platforms that we deliver are hybrid. So we have some national, we have some regional, and we have some local. We will continue to operate in that way, and we'll try and make sure that as much decision making as is appropriate within the guardrails that we work within takes place at the IHA level. So we will look to make sure that there's a business partner clearly identified, working with each of the IHAs, and that we'll have regional steering and we will have regional program steering groups. So an overall regional digital roadmap steering group and regional program steering groups for the major platforms that we're deploying. So we'll get those up and running in the March and April timeframe, as you can see here. The digital partners, as I've mentioned, by the end of March, and we will work through how a proposed model for the networks of care, so that there's good kind of cross-sharing of information with the networks of care and where digital may be able to help. But the primary governance will be through the IHAs and the regional digital steering. And then we have an opportunity, I think, to improve how we collect, analyze, and present our data to support operation. And so we'll work through an operating model for data over the course of this month. And myself and Mary Garvey in planning and performance are working that up at the moment. Thank you.
Thank you, Vincent. And Tony, back to you.
Very good. We were very efficient. So we're at 1:15, 5 minutes ahead of our schedule. Thanks everybody for cooperating with that. Just to repeat, and it was asked as one of the questions, the slides will be circulated to everybody that's in attendance, and I think we'll circulate them more widely and cascade them down through the system as well as we go. So we might go straight into the questions. So Caroline, if you don't mind, kind of
the first one, I think,
them or whatever it is. Yep.
Yeah, absolutely, Tony. I think the first one may be for you because it's a national piece as well. Is there any update re the Forza request for the model on governance for health promotion on transfer to public health to enable the lifting of the union non-cooperation instruction to staff?
Yeah, there's still work to be done on that. Unfortunately, it wasn't tidied up in advance of the 3rd of March. So we have a number of engagements with across the whole family of unions actually at national level. This is one of the issues that unfortunately still remains outstanding. I'm hoping that we will be able to get a sit down to discuss this specific issue and one or two others with Forza by the end of this month.
Great. This question, there are now leads for medical nursing and HSCPs. Is there a plan also for a pharmacy lead, as pharmacists do not fall under any of the above discipline categories?
So the short answer is probably no, Aisling. So yeah, it's the references to the regional health area management team, and we do have regional director of nursing and midwifery. We also have regional clinical director and regional head of health and social care professionals. We're not proposing to have a regional head of pharmacy on the management team. That said, pharmacists and others, and there are lots of others working within our health services, will be represented through their own line management. So if your pharmacist working within a hospital, you're reporting within the hospital, and of course the hospital then reports in through the IHA. But I think the straight and simple answer to your question is that it's not intended to have a pharmacy lead.
Perfect. The next one is actually for myself. So can we get an outline of the comms process in West Northwest? Since the new structures, we have no designated link for health promotion, and issuing via the generic email is hit and miss with a lot of lost opportunities with the national media campaigns missed. So on that one, Adrienne, we will be sending out the link for everyone and how they can get in touch with us, engage. We engage with the National Health and Wellbeing Promotion Team regularly, and we always make sure that we're sharing those out. We do prefer to make them more regionalised to our area. So anything that you have that can help with that and amplify it, we're happy to keep going, but we'll be sending out a link on how to engage with us on all of those pieces. So the next piece then, yes, copy of the presentation. We will be sharing this out, and it'll be shared out with the recording for all staff, including those who couldn't make it. We did have the full 1,000 registered, so there's a number of people who couldn't register after that, but it'll be shared so that they can watch it after the fact. The next one is on consumer representation. Has there been any consumer representation involved in the drawing up of this new structure? I would find this all extremely difficult to outline to any member of the public.
Yeah, look, Denise, yeah, fair comment. I know that may want to join in with me on this one. My first response would be, I think we need to, yes, there was consumer representation. There's a national steering group that has been established and working for some time on this, and there are consumer representatives on that national steering group for sure. But my suggestion would be that we just give it a little bit of time. It's inevitable, I think there's absolute clarity at the regional level. We know who's running the region. We know with clarity at the IHA manager level, that geographical split where we've got 4 IHA managers in place at this stage. It'll take us a little bit more time to get that type of recognition around the management structure at the level below IHA manager, and to become obviously easier then to explain it to others. What we'd really like though is that people start to identify with the management team, individual managers working in their own area. And I suppose one of the strengths of this system is that it's geographically based. So, so people will start to become more familiar with, as they use the services more often and more frequently, become more familiar with the people that are in charge of running them.
And I think, Tony, it's important to say that we've had patient service user representatives on our programme steering group. And we do have an engagement with a committee that's led up there by Jakob. I think he might be on the webinar, but and we are going to co-design how we further engage with patient service users for all of the change that we're going to make across our area.
Very fair comment, Denise, and you're definitely not on your own on that one. We can see there's a fair few thumbs up with you there.
Next question is to do with will the registered proprietor for the mental health approved centres sit with the GM for the particular area the units are located in?
Might ask you, Mary, to have a go at this.
Yeah.
There isn't a simple, straightforward answer to this one now. Mary?
No, but yeah, so the thought is at the moment, yes. So currently the general manager sits as the registered proprietor for mental health, and it's expected that that will remain for the approved centre within their CHA.
Okay, this is the first of two questions. There's another one further down that we'll get to on contract management support units. Can you advise to whom the CMSU will now report within the new structure?
Okay, so actually, Denise, if you don't mind, I'm going to broaden out your question a little bit, because I think this is application to a number of different people. So the first thing I would say is that if you have had a discussion with your line manager and you've been appraised of and advised of a change in your reporting relationship, then that's fine. But where that hasn't happened, then there is no change. All of these changes will be implemented through a process of engagement, including with yourselves, Denise, working with the CMSU, and that process hasn't happened yet. And it's one of those things that will be happening during the month of March and April, before we implement any change. So, so the simple answer to your question is that things remain as they are at the moment. Engagement is on its way, and the outcome from that then will determine where the reporting line is after that. The second question was?
So I'll get to it, Tony, because we're just taking them in order at the minute, if that's okay.
Okay, yeah, Chris,
So
no problem, no problem, no problem.
So we'll move on to the next one, which was in relation to HR and personnel admin teams in acute hospitals. Is there an update on whether these staff will be transferred to national personnel admin? And if staff are moving, is there a timeline?
So
Maria, Maria.
Yeah, so thanks, Jason, for the question. So as you've outlined in the new agreed operating model, some of the work that we undertake locally at site level will be transferring to the National Personnel Administration Department, or NPA as it's currently known. However, not all of the work that we currently do in that area is transferring. So we have been working with NPA since Q4 last year on a due diligence process to quantify what exactly is leaving and what is remaining. Once that exercise is concluded, we'll be able to identify what staff need to be retained locally in the region, and then what WTE the NPA are seeking to transfer. So it will take another period of time, Jason, to work that through, but similar to what Tony has just outlined, any individual staff who may be affected as part of that transfer will be engaged with directly and in adequate time prior to any transfer or anything like that being agreed.
Thanks, Maria. The next is to do with the HSCP managers. Can you confirm that the reporting structure for the HSCP managers will be the IHA leads, which was discussed at a meeting on the 13th of January with IHA and HSCP managers?
Feels like one for you, Mary.
Yeah. So what's referenced there is an engagement that we had with all senior clinical leaders across the West Northwest, where various options for reporting relationships were discussed and fed back into the national system to allow appropriate engagement with each of the individual unions representing those senior clinical leaders. Those engagements with the unions, as we understand it, are near completion. What is being proposed is the Proposal 1, which is the health and social care professionals reporting in under an integrated service lead. But we're waiting for confirmation of that, and we expect that confirmation towards the end of this week.
Great. So this is another question on the contract management support unit. Approximately 500 million of HSE West and Northwest funding will be allocated to Section 3839s and for-profit service partners in 2026. Responsibility for contract completion and management transferred to the regional structure in 2025 and continues to be a delegated function of service managers. The CMSU has greatly valued the support and leadership provided by the heads of service in ensuring that the various components of the governance framework were progressed and implemented. That oversight and organisational imprimatur were instrumental in supporting consistent application across services. As responsibilities are transitioning within the new structure, it would be helpful to understand which new roles will assume the functions previously carried out by the heads of service in this regard.
So, yeah, Mary, sorry, you're going to jump in.
No, I'll let you come in first, Tony, if you like, in case
a couple of things that I'd say. First of all, it's a really good question because it highlights the importance of Section 38 and 39 and the delivery of services across our region. So 500 million, that's out of 3.2 billion. It's a significant part of what we do, particularly prominent on the disability side. So a very, very important part of what we do. What I would say, Denise, is that that the operational responsibility for everything that happens within an IHA will sit with the IHA manager, and that means that, you know, so there are some Section 38, 39 services that are within the IHAs, and so the operational responsibility will sit with them. Now, I completely agree with you that heads of service have played a really important role in this process up to this point, and we're fortunate in that, with the exception of the retirement, I think that was mentioned earlier on, and in movement generally around the region, all of these people are staying with us. So we're not losing the expertise or the experience that that has been built up over the years with that. Now I'm going to hand over to Mary to maybe to answer the question a bit more directly.
Yeah, so it is envisaged, Denise, that the integrated service leads will have the same type of supportive role as they've previously had in the delivery of the services to our Section 38 and 39 partners. As we work through the month of March and April, those roles will be more defined. And our plan would be with both yourself and Donna to issue communication out to our Section 38, 39 partners, advising them of their link within an IHA. We're not quite there yet, but as we move to that, we'll certainly be engaging with yourself and Donna and clarifying each of the integrated service leads roles in that management piece.
Okay. This is a question about the dental service. Where will dental services ultimately lie? Primary care or disability ambulance services, or ambulance and scheme services? Will there be mixed reporting? We look after children, adults and patients with disabilities.
Yeah, it's a really good question, Aidan. Thanks for that. And maybe if I was to be a little bit controversial, I'd say it won't be within any of those. And if all of this these changes work, we were asking similar questions in a year or two's time, we wouldn't be referring to primary care, or we wouldn't be referring to individual pillars as they existed previously. We'd be referring to integrated health areas and integrated health services. So where will dental services sit? They will sit within IHAs, and their reporting line will be within that IHA structure. You're absolutely right. It won't change the nature of how dental services are provided currently. It is provided across the breadth of children, adults and people with disabilities. It's provided in schools. It's provided in acute hospitals for people that require that as well at times. So it won't change the way the services are delivered. What will change that is maybe the dental strategy. But dental services will sit within the IHAs. They won't be part of disability. They won't be part of primary care. They won't be part of hospitals. They'll sit within IHAs.
So we have another question on the HSCP reporting structure. That one is currently reporting to the GM and OPS, but this post will no longer be in place.
Again, I think we're just waiting for the final direction from the National Engagement of the Unions in relation to clarity on the reporting lines for the health and social care professionals.
Okay, so have we any idea when Bundoran and Ballyshannon healthcare assistants will be realigned with Sligo Leitrim?
I'm hoping that John Fitz is on the call. I might have an idea.
Yeah, no, I'll take that, Tony. Yeah, no, we're working through that. We're actively working through that, Marion, and the plan will be that will align with the heads of service and the GMs taking up their full brief in terms of, obviously we're still in that transition period, so we would expect that to happen in the coming months.
Thanks, John. I think this might be for you, Maria. For the new Regional Employee Relations Department mentioned, has discussion taken place with staff currently working in that area?
Yes, thanks, Jackie, for the question. So there's probably two key parts of this at the moment, Jackie, that are being worked through. The first is that there are, as you know, a National Employee Relations Department at the moment, and there are staff working within that department who are due to transfer to the regions. So we are just waiting confirmation, hopefully this week, Jackie, that those staff will be moving into the region, and then we will be able to confirm to each of them their assignment across the different service areas. In parallel with that, you will probably have seen, or hopefully have seen, an opportunity that we have advertised attached to a role that is being created supporting the Donegal IHA. So we are moving forward with the recruitment to that post. So once those two kind of key initial enablers are completed, we'll then be working with other colleagues across HR in relation to working and supporting that pillar as part of the new HR operating model.
Thanks, Maria. In relation to the National Counselling Service, where will this sit, with mental health, primary care or blended?
So again, to take Tony's point that when this model is fully operational, we'll be moving away from the care group structure. So the National Counselling Service will sit under an integrated service lead who has responsibility for that portfolio and for regulatory responsibility around our mental health services.
Thanks. And I think that probably is the same for its management structure, Mary, is it, which was an add-on to that question?
Yeah.
Perfect. If the discussion with Forsa re the non-cooperation notice may not be resolved for some time, how are staff supposed to manage that over the next few weeks, i.e. during handover times, etc.? It's a real concern for people.
Yeah, maybe Georgina, I'm not aware of the level of concern that you're raising there on that one, but maybe that's one for myself and Maria to take away and to consider in terms of the timeframes for our engagement with Force and the urgency with which issues have been dealt with. But yeah, I think it's important to note that there are changes that are taking place on the 3rd of March, or that took place yesterday on the 3rd of March, I should say, and there are others that will take place over time. But all of that will be worked through a process and hopefully, will be worked through a process of engagement and so on, that we will end up with the right result. But look at on the engagement with Force and indeed with other unions, there are a number of engagements that we have to still have. Myself and Maria might just take that away and see if we can have a discussion about the urgency with which it's been dealt with.
Thanks. So the next one is for Dermot and John, and just seeking details on the approval of older persons social work resources for the realignment of South Donegal to Sligo older person services.
Yeah, I'm happy to take this as well, Caroline, because it's specifically, I suppose, the realignment of South Donegal. So similar to my previous response, I suppose a lot of the realignment has happened in terms of across primary care, disability and mental health in recent weeks. So older persons is the one we need to conclude. I think, to go to Brendan's question there, that's part of the discussion in terms of how we can resource, social work and indeed home support and other areas like that effectively to make sure the governance is maintained and stabilised. So we're working through that at the moment, Brendan, and I'm happy to have a discussion with you offline in regards to that.
Okay, thanks. So the next one is, can staff below GM level be assured that the reassignment principles will be adhered to in terms of volunteerism, seniority, etc., when an independent adjudicator decision has already stated that there has been a breach of the principles and that this RHA has not allowed the volunteerism, which is at the very core of the principles in respect of the general manager reassignments? Also, will they accept the adjudicator decisions as per the PSA and reassignment principles, even when they don't appear to have done so to date?
Yeah, so I just addressed the first part of that question. The rest of it is maybe specific and maybe pointed. So the first part is about will we be adhering to the reassignment principles. So that refers to the principles for reassignment that has been agreed with trade unions and so on. And the answer to that is yes, we will, and we have been adhering to them.
Thanks, Tony. The next one is the home support resource managers. Who will they be reporting to?
So I suppose as we work down through from the general manager level below, there are a number of ways of working that have to be worked through, including pieces like the home support resource managers, particularly because that service is going to be regulated. So our old heads of service, along with the incoming integrated service leads who have subject matter experts within older people, are looking at those ways of working. And are going to firm up on those within the next 2 to 3 weeks. And then, as Tony said, the appropriate communication will go out to the relevant people that are affected.
Thanks, Mary. Dermot, I think the next one is for you. Our services within Letterkenny area under Donegal East or North, they appear to be central and difficult to make out. That might just be from the maps.
Yeah, it's from the map and it's Donegal North, majoritively. But there is services that will reach in and across each of the areas because they're not that far apart in terms of the border. CHA border, that is, not the 26 county border.
Thanks, Dermot. The next one is just a follow-up, Mary. It's saying that the registered proprietor role needs more clarity. Some services have no GM in mental health, and nor is it envisaged to fill these posts. When does RP, or where does RP then sit? For the example there is for Sligo Leitrim.
Yeah, so John may want to come in on Sligo Leitrim, but every CHA has a general manager. And the centres sit under, all the service unit delivery sit under a general manager. But John may want to come in specifically in relation to Sligo Leitrim.
Yeah, no, I'm happy to come in. So our approved centre is in Sligo. So the general manager for Sligo South Donegal will fulfil the role of registered provider.
Thanks, John. The next one's just about the Q&A recording. No, nobody needs to go to FOI for this. It will be shared out with all staff after this webinar, as all of the webinars have been. So the recording will be available to everybody to watch.
Okay.
We then have a question on the new AFO for finance reports. Now, this is not BECS and census data. Reporting be released to enable the new structures to be reported on.
Does Liam want to
That
have a
might
vote
make
that
more sense to you, Liam.
Yeah, I presume, Georgina, what you mean here is the new IFMS reporting system. So basically, the reports will be available. Finance will be available by IHA and by our community health group areas. That will all be built into the new system. But all the mapping is done since back into last year to do that. But I presume that that's what you're talking about. But if you're not, just drop me an email and we'll follow up on it.
Thanks, Liam. Is there a decision on where nursing home support fair deal will lie?
So again, Caroline, this has been worked through in the ways of working under older people. If no change has been communicated to date, then it remains as is until we see how the portfolios of the integrated service leads settle in. But that has been looked at by the ways of working group in older people.
Thanks, Mary. In terms of moving away from the care group structure, has there been engagement with the National Compliance Unit in respect of contracts moving forward? And I know Donna had come in down below to say that Section 38 and 39 contracts are currently designed per care group.
Yes, the short answer, Donna, but there are still changes. Obviously, there are still lots of changes that are yet to be made. And part of that is, having a system set up for the current year and then addressing it during the current year and setting it up maybe differently for 2027 and so on. But yes, it's the answer to your question, but more work still to be done for sure.
And Mary is looking to see about whether we will have diagram-like structures of the new area structures and the names of the manager over each structure and network. These slides will be presented, but I think they will be bottomed out, Mary, in more detail per IHA.
Yeah, so there are still some gaps and people moving to different roles within the IHA management structure. So once those posts are completely filled, there will be engagements at an IHA level, a similar webinar to this at an IHA level, sharing the detail at an IHA level, and that will also be available across, that information will be available across the region once it's all confirmed.
Thanks, Mary. Is it envisaged that some business supports will align with West Northwest IHA, or is it planned that this will continue to operate nationally for now, specifically the National Procurement Strategic Sourcing Team of approximately 100 staff that are currently under the National Finance Division?
So there has been some alignment already of some of the central functions, and that has been passed out to the regions. I think there's a good bit more still to come. Maybe not so much on the line that you've described there under finance and under procurement, but possibly under access and integration and their services that are currently under access and integration at national level that will likely transfer out to the regions in some sort of shape or form. Again, further engagement still required on the detail of that and how we work it out. Sometimes it's easier to just do things once at national level and then roll it out across the country. But of course, now we've got 6 regions, so how do we accommodate that as part of the complexity around it? So I think, Beatrice, the answer to your question is probably unlikely to see significant changes in finance and procurement as you've described, but possibly some further changes, I'd say, on the access and integration side.
Thanks, Tony. Is there a current adult disability service teams is the current adult disability service team being incorporated into the new network of care, or is it going to remain the same?
Yeah, Mary, sorry.
Yeah. So the adult disability services are operational services that are delivered out in the CHA. So that's where the operational units will remain within a CHA. And I suppose the network of care then will provide an overarching governance, standardization of delivery of service, learning from incidents, and a quality assurance around services. but the networks of care are not an operational, do not hold an operational responsibility for delivery of services. That remains within the IHA.
Thanks, Mary. This may be for you, Liam. Will budgetary responsibility for 2026 for delivery of mental health services remain with the area mental health management teams or move to the new realigned structures?
I'll have a go at that, and Liam, you can come in and correct me if I get any aspect of this wrong now. But so first of all, I think the simple answer to your question, Paul, is that the budgetary responsibility for 2026 mental health services, indeed for all services, is clear at regional executive officer level. So that's with myself, and at IHA manager level. So that's with Mary Ward, with Anne Constable, with Dermot Mullen, and with Jonathan Morris. And then within the IHAs after that, then with the assigned managers after that. So that's the structure that we have in place currently. There was a change in how budgets were managed across the HSE for 2026. That kicked off in December of 2025. We became notified of it then, where there was a much more significant degree of autonomy handed out to the regions, both in terms of the budget, but also in terms of the headcount and determining how resources should be deployed across the region in order to meet the needs overall. Mental health is part of that, but as the budget was sent down to us, the mental health part was identified separately. So we now have a clear headcount for mental health service developments in 2026, and we have a clear allocation for mental health, both in terms of developments, but also in terms of ongoing service delivery as well. So for 2026, at least, that kind of delineation in terms of the line in the budget for mental health is still there, and it's still very, very clear within that. But in terms of budgetary responsibility, it's along the lines that I described earlier on. Did I get any of that wrong, Liam, or do you want to?
No, that's fine. That's fine.
Okay, thanks, Dave.
Okay.
Okay, folks, so we seem to have come to the end of the questions, which is fantastic news. Tony, if anyone has any further, you've got a few minutes if you want to put them in, but if not, again, you can go back, take a think about this and come back to anybody on the meeting with any follow-up questions that you might have. But Tony, you might want to just say something there.
Just leaving a gap there in case there's any last question. I think we're there or thereabouts, so. All right, look at the only thing from my point of view again is just to say thanks first of all for joining the webinar this afternoon and for participating in it. And we do plan on obviously continuing with this process of engagement as part of the overall engagement process. So it will, there will be further webinars. I think the format is it works well, allowing people time to ask questions while presenting some information as well. I think it works very well. But if you're viewing that, we'd love to hear about that as well. And there's one last question just fit in there.
Yeah, I see that. So it's to do with the National Equipment Replacement Programme, Tony. How does this fit in with the new structures, and have we any update this year?
Yeah, it's the equipment replacement program will continue to be managed at a national level, which is good. And it's one of the things that has worked very well, I think, in recent years across the HSE overall. So to continue to be managed at a national level, there'll be sub-allocations at a regional level, and we'll work within that. Now, where it's specifically sitting for this year, I guess we'll have the detail of that contained in our operational plan, which will be completed over the course of the coming month. But yeah, that's how it'll work. It'll be continue to run at national level with allocations then at regional level, and then we'll divide it out within that. Okay. Anyway, so thanks for people's participation, but also thanks for your support for the process. Implementing change like this across our geography takes a lot of effort from a lot of different people, including a lot of people that are on this call. So I appreciate the fact that people have turned up, and I appreciate the work that people have put in getting us to this point. I think the message that I'd like to leave you with is that the 3rd of March was an important date. Yesterday was an important date for us because it changes our structures at the point at which services are delivered. That's important, so it is. But what's even more important is that we stay with the work from now to the end of this year, that we continue to implement and finalise and bottom out on all of those arrangements, because that's where the real value for services and for patients and service users, that's where it'll accrue. So thanks, everybody.
Right.